50% of renal transplant recipients may have peritransplant fluid collections, and they can include urinomas or hematomas, usually which occur in the immediate transplant, after transplant, um, lymphoceles, which can occur 4 to 8 weeks later, or abscesses. The relevance is based on the size, location, and possible growth of these peritransplant fluid collections. And the baseline size is documented because any increases warrant intervention, and it may be because of a urine leak, abscess, or vascular injury. The ultimate diagnosis can only be made definitively with the percutaneous aspiration. Lymphoceles are the most common peritransplant fluid collection, accounting for 20% of all of them, and they usually occur within 4 to 8 weeks after the transplant, and they're caused by disruption of the normal lymphatic channels during perivascular dissection or disruption of the hilar lymphatics. And they're usually discovered incidentally, and they don't need any treatment. But they do have the potential for mass effect, compressing adjacent structures. And they can cause hydronephrosis or edema of the leg, abdominal wall, scrotum, or labia as a result. On ultrasound, they are anechoic with or without septations. They can become infected with a more complex appearance also. The image on the left shows a septated lymphocele between the lower pole of the kidney transplant and the bladder, and the kidney transplant is labeled with a K and the bladder with a B. On the right side, you can see a 22 gauge needle going into the anechoic, well-defined lymphocele and aspirating fluid. On CT, they can be variable, they can be sharply circumscribed, and with attenuation like water, and they're usually lower than recent hematomas and abscesses may form. On scintigraphy, you can see a large photopenic region with a mass effect. Small ones should be monitored with ultrasound, and the larger ones should be drained if they grow or cause an effect, and they can be drained either percutaneous or surgically. On percutaneous drainage, there's simple aspiration, or you can place a drain with sclerotherapy, which will, and the sclerotherapy will lower the recurrence. And sclerotherapy can be done with povidone, iodine, absolute alcohol, or doxycycline. Hematomas are usually seen in the immediate postoperative period, but also can spontaneously occur or as a consequence of trauma or biopsy. They're usually small and resolve spontaneously, but larger ones can displace the kidney or cause hydronephrosis through compression. Acute ones appear echogenic, and they become less echogenic over time on ultrasound. Chronic ones may appear anechoic, and they look more like fluid on ultrasound. Septations may develop over time as well. On CT, their appearance is also time dependent, because acute ones can have high attenuation, while chronic ones will appear liquefied or serous. And on MRI, the acute one will have a high signal intensity on both T1 and T2 weighted scans. On scintigraphy, a hematoma will appear as a cold defect. You should document the baseline size of a hematoma that develops, and then note any increase in size over time. Greater than 80% of transplant recipients will have at least one case of infection within the first year, and early diagnosis and treatment can prevent graft loss in such cases. Risk factors for infections include immunosuppressive medicines, indwelling catheters, and frequent glycosuria. Peritransplant abscess is more rare, but it usually occurs within the first few weeks, and it may be due to pyelonephritis or bacterial seeding from a lymphocele, hematoma, or urinoma. Acute bacterial nephritis, renal abscesses, or perinephric abscesses may occur also. On ultrasound, they can appear variable. The focal pyelonephritis can appear as a focal increased or decreased echogenicity, but this finding is nonspecific for pyelonephritis. A focal increased or increased echogenicity can represent infarction or rejection, or an intrarenal mass such as renal cell carcinoma, PTLD, or an abscess. Abscesses can appear like complex cystic and nonspecific masses. On CT, you'll see gas in an abscess, which can differentiate it from other possible collections. Low-level echoes in a dilated paleocetal system in a febrile patient will suggest pyelonephritis. And abscesses are treated with ultrasound or CT-guided percutaneous drainage, plus or minus antibiotics. Graft dysfunction can be due to acute tubular necrosis, rejection, or drug nephrotoxicity. On grayscale ultrasound, graft dysfunction might show renal enlargement, increased cortical thickness, increased or decreased echogenicity of the renal cortex, or loss of corticomedullary differentiation, prominent pyramids, or collecting system thickening, or a central sinus echo complex effacement. These findings are subjective, though, and negative predictive values for them are between 17 and 50%. On duplex Doppler ultrasound, it's not those are is not a very specific test for diagnosing rejection. But if you see an elevated RI greater than 0.8, that's a nonspecific parameter for a renal transplant dysfunction, although the specific cause of it will require an ultrasound-guided biopsy to be diagnosed. And diastolic flow reversal is also another soft finding of renal transplant graft dysfunction. Some quick information about the resistive index. It's defined as the peak systolic velocity minus end diastolic velocity all over the peak systolic velocity. In the slide on the picture on the left, you can see on the graph in the lower left corner the peak systolic velocity and the peak diastolic velocity. You can note that the diastolic velocity is below the x-axis, and when it's below the x-axis, that indicates a reversed diastolic flow in the curve. And then on the right, the diastolic peak diastolic lowest diastolic velocity is above the x-axis, so there's no reversal of diastolic flow, and that's the same kind of principles you would look for in the image to your right on the spectral analysis graph shown on the bottom when you're measuring blood flow through the renal arteries. And in general, a RI greater than 0.9 is abnormal. Also, you can use serial resistive index measurements in conjunction with clinical and lab findings to monitor the transplant and decide for or against a biopsy. And resistive index less than 0.7 is considered normal, but although that's not always the case. Acute tubular necrosis is common in the early transplant period, usually within the first 48 hours, secondary to reversible ischemic damage to the renal tubular cells during warm ischemic time. It's seen in 20 to 60% of cadaveric kidneys. So risk factors include use of cadaveric kidneys rather than living donor kidneys, donor hypotension. It's okay to keep the patient a little hypertensive during a kidney transplant to make sure that the kidney is adequately perfused, and excessive diuretics or vasoconstrictors, greater than 30 minutes warm ischemic time or greater than 24 hours cold ischemic time can all lead to ATN in your patient, and 10 to 30% of these ATN patients will require dialysis. ATN is present in most of the cadaveric kidneys, but it resolves spontaneously over the first 2 weeks, and ATN is more rare in the living-related donors. And delayed graft function is usually related to the degree of warm ischemic time. And radionuclide imaging shows a delayed transit with delayed time to the maximum activity, and a high 20 to 3 minute ratio, and marked parenchymal retention on sequential images. Recovery in ATN patients on hemodialysis will occur within 1 to 2 weeks, but can be delayed up to 3 months. On ultrasound, the acute tubular necrosis kidney may appear normal, or it could appear enlarged, edemaceous, hypoechoic with a loss of corticomedullary differentiation, and it can have an elevated or normal RI. This image shows a kidney that has normal corticomedullary differentiation. Acute rejection is seen in 40% of transplant patients, usually in the early transplant period, usually 1 to 3 weeks post-transplant. It's normally reversed with high-dose steroids or antibody. Acute rejection is an adverse prognostic indicator for future chronic rejection or graft loss. Differential diagnosis for acute rejection is obstruction, infection, drug toxicity, and it's usually asymptomatic, but it may have flu-like symptoms, pyrexia, or graft tenderness. The likelihood of acute rejection is greater when there's a higher resistive index, absence of diastolic flow, or flow reversal. And serial ultrasound can be used to monitor the treatment progression after biopsy-confirmed acute rejection.